welcome to this episode of the Security Nurse Podcast. With me today is Dr. Michael Guirguis. Hi, Michael. How are you doing today?
Good. How are you, Sarah?
I'm doing well. Thank you for being on today.
Thank you.
So, for our viewers, I kind of like to start it off and kick it off with a question, asking my guests kind of a little bit about your background and what was that aha moment that has kind of led you to what you're doing currently today.
Okay. Yeah. So a little about me. I mean, we know each other through kind of the security industry. I am an emergency medicine trained physician. I've been doing it since 2003. Started my residency out in Southern California at a level 1 trauma center. And, I've always enjoyed emergency medicine. I've done a lot of kind of pre-hospital work, sports medicine. So I've done a lot of event medicine, concert, raves, NASCAR events where I've been track physician, infield care center physician, worked with some hockey teams, the NHL, actually the NHL's farm team for the LA Kings, Ontario Reigns. Emergency medicine is kind of what I do full time. I do love it, but I also do love the out of hospital experience that you can get with medicine and just that variability that you can provide medicine outside of the hospital. It doesn't always have to be in the emergency department. I've also been involved in law enforcement. In 2003, when I kind of came back from med school, I'd always been interested in law enforcement. I was kind of hindered from going into a career in law enforcement straight out of high school because of a football injury. And then I ended up having surgery in medical school in my third year. And that actually kind of saved me from lots of pain and grief. And I was able to go through the Sheriff's Academy out in Orange County, California, and became a reserve deputy with San Bernardino County Sheriffs and joined their aviation aeromedics team. So I've been flying aeromedics up until about mid-COVID, had some kids and kind of decided that maybe that risk of flying in helicopters and doing hoist rescues, do offsite landings and all that stuff up in the mountains was just a little too risky with two young kids. So, I moved over to Aero Squadron and Medical Reserve Corps with the Sheriff's Department, but still active with them.
So, a lot of experience both in and out of the hospital when it comes to medicine and security and safety. And what are you doing today too? Like you have the emergency medicine, but you also have your own company.
Yeah, so I have a Raven Medical Support Group. We do a lot of med direction, medical oversight for security teams that have either embedded security personnel that have EMT or paramedics on the security teams. Or I also work with XPJ, which is a group of Special Forces medics, all pararescuemen, Air Force pararescuemen, either retired or still in the reserves. And we can provide on-site security/medical support to security teams that already exist who just don't want the overhead of kind of having a in-house medical team with medical direction and everything that comes with it.
Gotcha. So a pretty fluid kind of transition and incorporating what you were professionally trained to do into kind of a business now today that you're running.
Yeah, I mean, I got involved just dumb luck. A buddy of mine about 5 years ago, who I'd worked with, who knew about my medical, obviously my emergency medicine experience, along with kind of the law enforcement experience. And he had a friend who they needed a medical director for a private family office up in the Silicon Valley for a high net worth client. And that was my exposure to that industry where I didn't know what executive protection was. I didn't know what private family offices were other than medical private family offices, but there's private family offices that these high net worth clients have that kind of provide security, wealth management, kind of risk mitigation with lawyers, insurance, and things like that. And there's a lot of high net worth clients that have that. And I was never aware of it. So that's kind of where Raven Medical kind of works in that field. We do work for corporate sponsors, or so I shouldn't say corporate sponsors, but we do work for corporations who do have executive protection teams who may or may not want to kind of delve into the medical side of providing a medical aspect to their EP teams. And so I work with a lot of the big corporations.
Gotcha. So I'm kind of more like on an as needed basis if they need a medical team for a specific like trip or something like that, right?
There's some corporations that just don't feel that there is high enough risk that they need full-time 24/7 medical support. And then there's some that just want to kind of use it ad hoc if they're going on a trip, maybe to a country where there's not going to be kind of tier one medical support in terms of hospitals, EMS in the area. Then they can usually bring on one of our PJs that will travel with them and provide that medical support, help medical evacuation if we need to. I mean, we've done some pretty high risk, very difficult medical evacuations in the past. One just recently out of Haiti, getting a security contractor out who had injured himself, and we're able to get him out of Haiti, which was a difficult task, but was able to get done within 24 hours. So those guys are really good at what they do. They've got lots of connections. We just so happened for that have a ground controller that was already in Haiti and was able to get all the necessary okays and approvals to land in Haiti and get in, extricate the patient and get out.
Wow, so like a lot of it sounds like a lot of logistics, I mean, honestly, to tell you the truth.
Yeah, it is because just kind of Haiti's in turmoil right now. It's not a easy in, easy out. You've got to have permission to land at the airport. That's pretty much a semi-military base at this point because of all the turmoil that's going on in that country.
That's amazing that, you're able to do that and help support with that. I'm curious if so you said you kinda got into this about 5 years ago, but you're still practicing in the ER too. Did that experience of kind of getting involved with the executive protection and the medicine side of that change how you viewed the ER a little bit or how you did things?
I think the emergency department gave me an experience being able to work under kind of high pressure situations, sometimes without the greatest of support with personnel or even consultants and things like that. So you have to just kind of make do with what you have and hope for the best, and just try your hardest. And that's kind of what the EP industry is like, right? You can't have everything and anything you want at your fingertips, especially when you're traveling. You're in other countries where there's going to be limitations on equipment you can bring, especially medical equipment, medications. I mean, our over the counter medications that are legal here that you can buy in a store may not be legal in other countries and get you in a lot of trouble. So you've got to have to work around that. But I think between emergency medicine and kind of the law enforcement, that the security mindset, uh, and I've kind of always had that. And I think that's probably what got my interest in law enforcement. I just have that kind of mindset. I'm always kind of aware of what's going on, probably overly aware sometimes where it's just like, all right, you need to relax a little bit, but still, I think it's good to have that kind of awareness, kind of have that gut instinct of, what could go south, go sideways. You just kind of get a gut feeling about a person or just the way someone's acting or looking or standing or posturing. And, I think it's a great thing to have. And not everybody has it.
I would agree with that because I have some core memories from when I was a child and now doing kind of the security thing and being more involved in that. It makes a lot of sense. I do think it's a little bit of kind of maybe how you're wired. And some, healthcare professionals are better at de escalation than others, right? I think it's just kind of the way that we interact with people and can read people in some.
Yeah, I think with real quick, I think the de-escalation part, I think is just ego driven, right? So I think those who have high ego, my way or the highway, have a really hard time de-escalating something because they want to be like, I'm right, you're going to do what I say. And sometimes that doesn't work. I mean, even with de-escalation, you're basically trying to get your way, but you're trying to do it in a way where, the opposing side kind of feels like they're winning in some kind of negotiation and that they're winning. So, it's like kind of like the art of the deal of negotiation where you're trying to get what you want, but you also want the other side to feel fair and they got something out of it. So, and if you're
Yeah,
okay with that, you're probably going to be pretty good at de-escalating.
no, I agree. It's definitely putting the ego aside and realizing that it's more about that person that you're trying to talk to than it is about yourself, right? And I almost wonder if it's like cooperation negotiation, right? It's not necessarily de-escalation, but more about cooperation and how can both sides cooperate and reach a common goal.
Right. Absolutely. 100%.
I'm curious, I've been trying to get a little bit more like kind of personal stories on the podcast. Is there a situation, like a high stress, just high level kind of situation that you've been involved in the emergency room? I'm kind of curious if you could share that. And then maybe like Monday. Monday quarterback kind of lessons learned afterwards?
I mean, there's a lot of things that are high stress in the emergency department. I think kind of the most stressful things in the emergency department is usually when you're dealing with young kids. And I trained at a trauma center, which was also a pediatric trauma center. But I do remember just being 30 years old, 28 years old, a resident in residency and having a peds trauma center. You saw a lot of it. And to be honest, I can literally not think of kind of one bad thing. And I literally think it's just protecting yourself because you have so much trauma in the emergency department that you have to just kind of pack it away somewhere and just keep it out if you're conscious.
Yeah, or it just kind of starts to all blur together, right? A little bit because it is so much that you're dealing with.
It's just that protective mechanism in your brain that, but I do know, and I do know that it's always around young children, and I can only imagine what it would be like having a young child now, and then seeing another young child in distress or extremis, and trying to help them out. It does kind of get the heart rate and the blood pressure up, and it can be very stressful. In terms of Monday, what is it? Monday back quarterbacking or
Yeah.
whatever they say. Was it Monday night quarterbacking? I think just with experience, even with that high stress, you have to rely on your experience and just kind of doing what is rote to you. You're not actively just kind of thinking about what you're doing when you're seeing a patient. You've got a routine. You know exactly what you need to do, and I think you have to rely on that. And that's something we talk about in executive protection, right? So you get these security professionals who don't really have a medical background and they're putting on tourniquets and, they're doing it in a nice, quiet, well lit room, sitting there, having a soda while they're putting on tourniquets, laughing and joking. And then you just kind of realize in real situations, it may be, dark out. You may be using flashlights. You're going to have people screaming, yelling. You're going to actually have blood, squirting. So you need to have that real life situational kind of awareness of what is actually going to be happening when you're putting on a tourniquet. It's not going to be nice and calm. I actually just gave a talk last week to some of the Native American tribes in Southern California that have casinos and they've got security teams and EP teams. And we just shown a video of a LAPD officer putting on a tourniquet on a patient and you could just tell, I mean, he didn't really have the training in kind of real life scenarios, like how it's really going to be. And it was a mess. And it's no fault to the officer himself. He's showing up to his post training, which is our California kind of umbrella organization for law enforcement training. But he's showing up to his post training, his 4 hours a year. And that's mostly computer based and maybe shows up to class and puts on a tourniquet 2 or 3 times. And that's the training they get. It's more of a check the box training than it is like this is something that's really important. So that's something I let our folks know is like, listen, I know this is all kind of fun and games and it looks really easy, but when your heart rate's going, your pupils are pinpoint, you're sweating, your respiratory rate's at 30, your fine motor skills are now gone, everything is like a big bumbling mess. It's hard to do it.
Yeah, do you have any recommendation? I mean, do you oversee any kind of training for the medical personnel that you hire for Raven?
So it's usually for the clients, so it's private family office clients. We do medical training. I've been lucky. The clients that I do work with do kind of take it seriously. I think once they kind of reach out to me and bring me on board, half the battle's already over because now I know we have administrators on that team that want actually high level medical training. It's not just a check the box type thing. There's a lot of security groups that just want check the box security training. Oh, go take this TCCC class every 2 years. We'll pay for it. Just show us the cert. It's one of those things. I mean, it's better than nothing. But if you're not doing this every few months, at least doing some kind of mini refreshers, mini training, you're not using these skills every day, right? I mean, it would be like us in the hospital. If I did a central line once every 2 years, 2 years out, I wouldn't know what I was doing. I couldn't remember. I wouldn't know what I was doing. It would take 3 times as long. I'd be probably on YouTube somewhere figuring out how to do it again. It's just something that you just have to do. I mean, that's just the reality of it. So if you're not practicing, it just becomes very difficult.
Yeah, do you have any suggestions for kind of setting up those trainings and those practices every couple months?
I mean, the easiest thing is if your company is, all on board, they set them up for you. I mean, it's mandated, right? It's part of one, it's your 40, 60 hour work week, whatever whoever the group is, I mean, we have rotating trainings. And it's not me all the time. Sometimes it's one of the medics that's had some, medical experience outside of security that's running the trainings. And then just to do just just completely kind of buy into it. And it doesn't mean that on a random Wednesday when you're doing residential security at a residence, you don't just pull out one of the training tourniquets and practice putting it on, practice putting it on upper extremity, lower extremity, practice it, putting it on one handed, even if it's a lower extremity. Just imagine your left arm doesn't work and you have to put it on your left leg. Just do scenarios, do it with your eyes closed, you know, just do it by feel. You should be able to do it by feel because what if you get pepper sprayed and shot? What if it's dark out and you can't get your flashlight? What if you have a flashlight, but you can only use one extremity? You can't hold the flashlight, with the other extremity. So you got to use the tourniquet for that extremity. So it's just things you could do to train. It's easier said than done. I mean, even in the in the medical profession, a lot of the trainings we go to are check the box trainings and it'll
Yeah,
take it. I mean,
or
I mean,
we're sitting there with our refreshments
yeah,
and
exactly.
yeah.
It's a tabletop experience. It's this is where you go for a fire and half the time you're not paying attention. You're just eating lunch. So, I mean, I get it. It's kind of preaching to the choir, but yeah, I mean, I think that's the reality of it. And usually when it does become embedded in someone's mind, it's already too late because something already happened and now they're going to take it serious. And that's usually what I see is people don't want the medical side of the security until something medical happens. And then it's a big rush to get it.
Well, and that's kind of what we're seeing kind of in the hospitals, today too. We've had some significant, security events happen within hospitals just in this last week. Executive protection in healthcare has become a big topic because of what happened in December with
Hmm.
the United Healthcare CEO. So, how can we as employees, do you think, work on things ourselves and be aware? Like, what kind of resources are out there?
Yeah, I think you just have to realize as an employee for any corporation, I don't care how great of a corporation or how bad of a corporation it is you have to know that your security, your well-being is on you. It has to be on you. So when you walk into a new building, if you don't know where the exits are, if you don't know how to get out of a situation, if you're in a room that could be high risk, you just need to know how to get out. Where are your exits? Even windows. I don't care if you got to put a chair through a window to get out of a building, or how am I going to lock the door? Is this a door that swings in, swings out? A lot of people don't think that way. I kind of think that way. I'm not paranoid to the point where every time I'm in a room, I got to figure out how I'm going to get out. But I am pretty cognizant of kind of where my exits are. How can I barricade a door? What would I use to barricade a door? I don't run around with door stops and things like that in my bag. I just don't do that. But I am aware of what I can use to barricade a door. You have to own your own security because nobody else is going to do it for you. I mean, the hospital I work with, I'm on the disaster committee. We do active shooter training. We bring local police officers, SWAT teams. They'll do, a yearly walkthrough and they'll do scenarios.
I mean, well,
You just,
it's helpful, right? But
it's helpful. Right.
the truth is, I mean, there's a response time, right? There's a response lag time between those security responses and the immediate situation. So to prepare yourself and educate yourself more efficiently in those security tactics, like you're saying, know where your exits are, know weapons of opportunity in the room if you had to protect yourself, know body language when you're dealing with somebody. Those are all really important things that we as the individual need to know, because you're right, it's on us for those first 1 to 5 minutes. It's on us. We're the only one in the room, we're the only one in the situation, right?
All right. Yeah, and it's hard for the nurses too when you think about it, because the nurses are the ones who actually spend the most time with patients, and they're usually one on one. They're doing procedures, putting IVs in. They're focused on one thing. They have no clue. They're not making eye contact with the patient while they're doing it. If a patient decides he wants to swing at your head, he's going to, and he can, and you wouldn't have. any clue that he was. So, we put our kind of healthcare in compromising positions, but we don't expect or assume that we're going to get hurt in a hospital when we're trying to help other people, which is it's wild. But in this day and age where you've got intoxicants, drugs, psychiatric issues that may or may not be related to drugs, there's going to be wild things that do happen. And we're also dealing in an industry where there's death and dying, and there's people who see what we're doing as wrongdoing. We're there for the money. We're not there to help. We're pushing drugs. We're about the big pharmaceutical corporations. I mean, there's a lot of talk out there, and there's some truth to it in terms of, I mean, there's things with corporations with pharmaceuticals and just healthcare corporations who maybe not really be out there for your health, and they're more of a money making industry and not just a healthcare industry. So I mean, I get it. I mean, but you just have to be aware of that and see it for what it is.
Yeah, in talking with you, and I don't know if anybody else has really talked about this. I mean, we talk about the drugs, the alcohol, that sort of things, but I think we are starting to see a new type of violence in healthcare, which is like an ideology violence, right? So it is those beliefs against big pharma, or during COVID, it was a lot of like the anti-vaccine, right? Like, I don't want that COVID vaccine, and people were finding themselves in violent situations because people didn't want the vaccine forced upon them. So it almost does kind of seem like we are starting to see more of kind of an ideology, people's beliefs and their values kind of trickling over into those causes of some of this violence that we're coming up against.
Sarah, I sorry, I completely missed the last 10 seconds of that. So,
I was talking about the ideology, how I think maybe we're seeing a little bit more violence in healthcare, kind of more related to the ideology types of things, vaccine hesitancy, beliefs on drugs and alcohol, and then like you said, big pharma, medicines. I've had several, just verbal interactions, aggressive verbal interactions with patients that, you doctors don't care about me, you nurses don't care about me, and get cussed out because
mhm,
we're lumped in with the medicine of you don't care about me. And that's an ideology, right?
right. Yeah, no, I get it, and it's out there. And I mean, I think post COVID, during COVID, I think post COVID, all this changed. I think there's a different ideology in terms of healthcare. I mean, there was a big push by hospitals to force everybody to get the COVID vaccine. I, I'm not paternalistic. Let's put it that way. If you want it, take it. If you don't want it, don't take it. There was a lot of people saying, well, if you get COVID and you weren't vaccinated, we shouldn't treat you. Well, that's stupid.
Mhm.
Imagine. So then, should I not treat trauma victims that ride motorcycles because I think motorcycles are dangerous? Should we not treat NASCAR racers who decide to go in a loop around a track at 220 miles an hour? If they crash, should we say, well, you did something stupid, we're not going to treat you? I mean, that's just a stupid thing to say. But that's how they try to get people to take the vaccine. Well, guess what? If they don't want to take it and somehow we give our best efforts and they die, it is what it is, right? I don't tell someone they should or should not be DNR, DNI. I don't tell them, oh, you should be DNR, DNI, and I think you're really sick. No, that's their decision, right? There's some people that I think we should be aggressive with your cancer and treat it, and they've just decided they don't want to. So everybody should just kind of stay in your lane. Everybody has their own autonomy. They have their God-given rights to do as they please. If it's not affecting you, then just leave them alone.
Yeah, no, I'm actually putting together a PowerPoint for school right now on the four principles there: the autonomy, benefits, non maleficence, and justice, right? And
Hmm.
so people's autonomy, and I think that's part of the issue too, is patients want to feel like they have the autonomy to be a part of their care. And COVID definitely changed a lot of that stuff. And I think my biggest point is just, looking beyond the drugs, the alcohol, and the mental health to really look at this healthcare violence crisis. I mean, ultimately,
Right.
it's a crisis that we're dealing with, and look at it kind of beyond those three things and really find some root causes of what we're dealing with.
Yeah, I mean, what do you think the kind of the top 5 reasons why there's healthcare violence? I mean,
Yeah.
in my mind, I think it's drug, alcohol related. It's families or friends of family members who may have died in the hospital or have a very bad diagnoses or feel like they've been mistreated. I mean, they all seem to be kind of targeted in terms of violence, not just random acts.
Right. No, so I mean, I would say like drugs, alcohol, mental health, right? Grievances. Well, I would actually put ideology above grievances because if you're going to say, and I think that's where you have to really make sure that you're defining workplace violence. It's not just physical violence, right? It's that emotional, verbal assaults that you're dealing with as well. So, I would say kind of that ideology like I was just kind of talking about big pharma, medicines just out to make money off of me, vaccines, ideology about vaccines, and then I would say the last one would be kind of the grievance. I would
Mhm.
say those are probably the top 5 that I'm really seeing in healthcare.
Yeah, because I can't think of any other situation. We've actually had a shooting in our hospital maybe 20 years ago, and it was a patient who'd had a bad diagnosis of prostate cancer, and he decided to show up to the urologist's office and shoot him. And the urologist lived, but it was a big deal. But yeah, it was just basically someone who just wasn't coping well with their diagnoses and needed a scapegoat. So,
Yeah. Most, I mean, statistically, most deaths in the hospital shooting related are domestic violence. So I guess that's one that I left off there would be domestic violence, right? So usually it's an ex-partner or something targeting an employee, or it's like patient on patient, right? So we had the labor and delivery. We had 2 incidences of labor and delivery shootings, I think it was last year, right, in Texas that was related to domestic violence, where nurses and security got hurt and injured in those instances because the perpetrator showed up to labor and delivery because their girlfriend, was having a baby, and it turned into a domestic violence situation with a weapon involved.
yeah, it's yeah, it's
Yeah, and it's just having a deeper understanding of those situations, and I think what I'm seeing is that we're so focused on the drugs, alcohol, and mental health, and as clinicians, we haven't really started to investigate and research those other causes, right? The domestic violence. I still see so much misunderstanding about, like, what course of control, really is and really looks like in a domestic violence situation, and then that ideology and how that's impacting the patient's behavior.
yeah. I think another big thing is just emergency department. So I mean, emergency departments seem to get the brunt of it. And you think about it, it's people in pain, people in distress, and then you've got crowded emergency departments, just causes increased stress. And I mean, the outburst is insane in the emergency department. There's not a day where there's not a patient outburst, loud complaint or something that could be construed as, violent behavior. And the reality is you can't really do much with it because of EMTALA. If you've got someone homeless, maybe on drugs, and they're flopping around in the emergency department in the waiting room, you got to either bring them back to get them away from everybody else, but you can't deny them services.
Right. And I don't see that changing anytime soon. I mean, that's such a fine line on whether, you can give services or not. So it's really like, how do we deal with that knowing that we have to accept those patients, right?
Right. Yeah, I mean, but medicine, the medical industry brought that upon themselves for doing lots of shady things, many years ago before the federal government jumped in. I mean, when you're taking patients who aren't payers and basically refusing services and letting them go to another hospital that will take them because they're not, good paying, customers. I mean, that was something the medical industry brought on themselves. So they've been hand slapped by the federal government, and it's probably never going away.
Yeah, no, absolutely not. Well, and I've been kind of walking this fine line of, I see a lot of posts of like, where's the metal detectors? Where's this? Where's that? And, unfortunately, like I'm trying to very with some couth and tact say, hey, but let's turn the mirror around for a second and kind of look at our own involvement in this violence that we're experiencing in healthcare? What was our complicence, how are we
Hmm.
complicit to it?
Hmm. Yeah, I mean, so we have, I've been very vocal about having armed guards in the hospital. And so we actually have now two armed guards in the hospital, and it's a big hospital. They do have detectors through the emergency department entrance, but the other entrances aren't. They've at least they see that the emergency department has got a little more risk than just kind of the average person coming into the clinic during the day. I mean, it's a great start. It really is. But I mean, I can tell you now that would have, if the president was coming to our hospital, that's not going to be the level of security that would be there when the president's coming. So, I mean, it's great for deterrence, but if someone has a will, they're going to get in. It's not hard. If you just did a little surveillance, counter surveillance, you could figure out what doors to get into, where to go, just walk around. So I do give credit to my hospital for doing it, but there's a lot more that can be done.
What are those things that you think can be done?
I mean, this is probably, to be honest with you, I mean, there's a policy where I cannot carry in the hospital. I'm a reserve deputy. I've been a police officer for 21 years. I've got a, CCW, a carry concealed weapons permit. I would say I'm um, pretty good at what I do with a gun. I've been around guns for 20 plus years. I would love to carry, obviously concealed. Nobody would ever know. I mean, most of the time I do carry and nobody ever knows unless it's other security personnel and they need to know. But I think I'm all for that because I could stop something within 30 seconds to a minute versus, maybe even our armed guards that could be, 200, 300 yards away on the other side of the campus. I mean, if someone wants to do damage in a hospital and just kill, it would very easily, you could probably kill 5, 10, 15 people within a minute.
Yeah.
You don't have to be that good of a shot. If you want to just maim and kill, it would be very easy to do. And the only thing that's going to stop that killing is a good guy with a gun that's going to stop the bad guy with a gun.
Yeah, no, and you're right, and it's how do you balance that, security and safety with access, right? Being open and being inviting. I'm actually a little disappointed because I feel like COVID and the lockdowns were a missed opportunity, right? A missed opportunity to kind of keep that level of security and to keep that level of access in place. I know things like kind of started to open up, but we started to create a norm for those 2 years in which if we would have just kept kind of that closed access, I don't think there would have been very much pushback from the public because it would have been something that they would have already started to get used to. Those procedures would have started to get in place on checking people in a little more quickly, getting them to where they
Mhm.
needed to go. For whatever reason, it was decided that we just kind of needed to open back up access, to all these places and not have some semblance of keeping the flow in a more secure fashion, right?
Yeah, I'm trying to remember COVID. It's one of those things where you just kind of, you repress it into the back of your mind. It was just, I mean, we had a time during COVID for months where I'd show up to work and there was nobody around. Everybody was so afraid to come into the emergency department. And I can just recall being in there for a 12-hour shift, seeing 5 people maybe for the whole shift. And the rest of the time you were doing something else in your office. You weren't working. A couple months later, waiting room 80 plus deep, 10, 12, 14-hour wait times. But we had a part in that because our clinics were closed. Everybody was closed. Anybody who wasn't a urgent care doc or an emergency doc or, possibly a surgeon who needed to do emergent surgery was sitting at home doing nothing. Everybody was afraid to come in. And then you get all this backlog and people get frustrated and they get upset. So, I mean, we could have done COVID a lot better. I think people just got used to staying home even after the kind of the max fear and anxiety was over. People still didn't want to return because they really enjoyed getting paid to sit at home, and that's the way I see it. So yeah, I mean, there was lots of missed opportunities during COVID, but I mean, we have to figure it out now and pay for it and figure out how we're gonna make it better.
Yeah, no, and I think I'm thinking more maybe like year 2 into COVID when, like, offices started opening back up and more of, like, those front door entrances, so maybe not just the ER, but the front door, like, the front lobby of hospitals were still pretty, like, bottlenecked, right? You had to go through, you had to get your temperature scanned, you had to get a sticker put on, so there was a little bit more kind of control access going on at those front lobbies for the main hospital that we just kinda did away with.
Yeah. It's expensive.
It is expensive. It
It's
is
expensive to
expensive.
have two people there, doing that 24/7 or, 16 hours out of the day, and I think that's what it comes down to is it just becomes very expensive to lock down a large facility like that. And then you get the administrators who are concerned about just kind of having that inviting, open feeling. Last thing you want to do is be a 9 month old or 9 month expectant mother trying to go deliver a baby and have to go through, the scanner and through controlled access on the happiest day of your life. So, I mean, I get it. I see both of it, but I think as more of these hospital shootings, violent encounters in the hospitals occur, we got to step up and do something.
Yeah, absolutely. I'm curious kind of for the executive protection stuff, what kind of, like, risk assessments and things do you do for that?
So, like the medical risk assessments,
Mhm. Yeah.
or yeah, so I keep separate kind of the medical side from the security side. So any team I work with usually has chief security officer, has managers on the security side. I have team leads and things. Um, on the medical side, I mean, everything is kind of tailored to the client, family members, C-suite executives, kind of whatever organization we're working with. I try to get information from the actual principal, medical history. Sometimes they're okay with giving information. Sometimes they keep a little more information to the cuff. But what I like to do is kind of get that medical information, just like you would get, a history of present illness, getting a past medical history, surgical history, knowing what allergies, what medications they're on, and then training the team to that patient specifically in terms of like, son has asthma and is really anaphylactic to peanuts or has mild allergy to peanuts. And then we just kind of work on scenarios. It's what I call like a medical threat assessment. So using the client, the patient, their medical problems, and then trying to figure out, okay, well, if we're going to go on a yacht and we're going to be 30 minutes away from medical care, what do we need to do to kind of treat the patient while we're actually transporting to a higher level facility? And then we just train on it. So, what do you do for asthma, mild asthma? We provide medical depending on who the team is. If we've got medics on board, we run with epi, we run with sodium medrol, we run with IV fluids, we run with IV Benadryl, we run with all the things you could actually do in an emergency department because we've got that higher level paramedic care. If we've got an EMT, we're just very limited on what we can do. So we do kind of that medical history, then we'll do that medical threat assessment, and then we can do the medical advance piece, which is okay, who's going on this trip, where are we going, and what is it? It's like a security advance. Security teams will advance hotels, they'll advance venues that they may be going to clients or advanced restaurants. Like, where are they going? Where are they going to sit? Where there's the exits? How do we get out of a situation if something goes sideways? And we do the same thing on the medical side. I mean, sometimes we can liaise with hotels. Like, do you guys have a on-call doctor? Do you have medical staff? Where's the nearest hospital? How do we get there during what time of the day? Which is going to be the longest, shortest route to get to a hospital, depending on traffic? What's the EMS agency like? What are their response times? It's just there's a ton that you could just kind of think of, and it's just kind of having that mindset, doing it enough to realize kind of things that can happen, things that can go wrong, and then just kind of addressing them beforehand. So it's not one of those last minute, what are we doing? Where are we going? And then trying to figure it out last minute. So a lot of it is just pre-planning and training. I don't go on 95% of these times. I'm not there. It's just the training for the medical folks. I'm always on call. I'm always able to take a phone call. I'm always able to help. I'm always able to help facilitate a transfer or an evacuation or make a phone call to a hospital and give a heads up if someone's coming. But I have to just make sure that the guys that work under me are just trained and trained well and ready for the situation that could occur. And there's situations that we just don't train for because, acts of God, just random things will happen. But, it would be a shame if we weren't trained up well on asthma exacerbation in a kid that we know has asthma and peanut allergies. That would just be a shame. You have to be ready for that.
Yeah, no, that makes a lot of sense. Kind of being ready for what you know are potential issues. And then, having a little bit of training for maybe those acts of God, tornado training or some, understanding how
Right.
to, how to respond in a tornado for sure. So what sort of who are the types of professionals that you employ then to be on these teams?
So under Raven, I don't really have, other than a few folks that I work with, I don't really employ anybody. What I'll usually do is go in with a corporate team, and either they're going to want to employ medical folks on their security teams, and then they'll do that on their side, and I'll come in as kind of the med direction with the protocols and be able to help with oversight, QA, QI, all those. Or you've got corporate teams that, let's say, 300 days out of the year, they just don't feel like they need any kind of medical assistance whatsoever on the security teams. They're up in Silicon Valley, they're in Palo Alto in a high rise, and Stanford is right down the street. All they're going to do is call 911, or they're going to transport themselves. But there's days where they're going to, get on a plane across the Atlantic, go to India for 2 weeks, and they're not comfortable just not having medical personnel with them. And then for those kind of trips, we've got a medic that can fly with you if something happens over the ocean. Anything can happen over the ocean. You can't just find the nearest airport. You got to keep going one way or the other. So you're either turning around, or you're going, to Europe or India. So I think a lot of times they want medical folks there. And then we can just help kind of plan depending on where they're going. We just plan for a trip. Client wants to climb Kilimanjaro. And so we had to start pre-planning all the vaccines. A lot of vaccines you can't just get and go. You got to get them 2 months, 1 month in advance. You have to get them in advance. We can help kind of plan for that. We can make sure that medications for travelers' diarrhea, parasitic infections are with the patient, or with the client, I should say, and that our medical teams are trained for that.
Gotcha. And so, correct me if I'm wrong. So part of that is a lot of those advanced kind of like medical, so EMT, trauma, that sort of stuff. I think possibly sometimes nurses are employed in those teams. I know there was talk of wanting some nurses on teams previously. I was approached a couple of times, but I just don't have that type of lifestyle where I can just up
Right.
and go. But it's because like those licensed professionals actually have to practice under a medical director, right? So even though, correct?
Yeah. So EMTs have EMT basics, EMT paramedics, their scope of practice is basically under a medical director. So they can't just go to EMT school and then just say, I'm an EMT, and just do whatever they want. Even within state protocols, you have to have a medical director. In terms of PA nurses, different states have different rules. I think for nurse practitioners, there's in California, I think there's an hourly cutoff where if they've done so many hours, they no longer have to work
Under a
under
physician.
a physician. They have their own autonomy. In terms of nurses are employed. I mean, I know there's a lot of kind of maritime work, all the yacht work, where they'll have full-time nurses on the actual boat, and then we'll kind of come in as the EMTs that can kind of provide more of that medical care. So, with the PJs, I mean, these guys are all rescue divers. They're all dive masters. They're all parry jumpers. So they can parachute. So they're very comfortable in the water. They're very comfortable extricating patients out of the water, where a nurse maybe on a yacht is not going to be that comfortable doing it. So we can kind of, while the principal's having kind of fun on the water with the water toys, we can be there providing kind of helping provide kind of security, but also having that medical background in case something were to happen. I mean, we've had stuff on the boats where someone got run over by a boat on a jet ski, and it wasn't our client, but it was one of the nearby boats. And our guys, with our clients, permission, basically went out and rescued them, and brought them to shore and helped kind of do a medical evacuation out to Florida, because they're out in the Bahamas at that time. But yeah, it's when you need it and you have it, it's good to have. When you need it and you don't have it, you're going to wish you did. And that's kind of when we get calls going, okay, we're ready. We need some medical folks.
Gotcha. So how could someone like so for me for nursing or an EMT, interested, how would they maybe find their way to that type of career?
Contact you, contact me. Even though I don't kind of hire direct, I get calls all the time, and I'll get resumes from folks that are interested in the work. A lot of times for something like this, because XPJ, there's specifically just kind of pararescue men. They don't hire in terms of just kind of nurses or EMT medics. The
Right,
whole
they're not
basically premise.
posting on, they're not posting on
Right.
Indeed or something like that.
Right. Most of the time, you're going to have to work for one of these private family offices. There's other companies you can find that will hire folks. I don't like that. I don't want to have to manage people kind of under Raven. It's a lot easier for me to just manage folks and let them kind of deal with all the employee benefits and all the different laws and regulations in terms of employment. I don't, these offices, that's what they do, right? Because I mean, they employ hundreds of people. I don't want that. I like to do the medicine. I want to do the oversight. I want to do the training. That's what I want to focus on. I don't want to become an administrator for like a medical business. But yeah, you can reach out to me, contact me on LinkedIn, just my name, you'll be able to find me, or they can reach out to you and, feel free to give them my information and I'll do anything I can to help them kind of get a job. It is a job for those who have time. I mean, I've been offered to go on long trips to China, to Macau, to boats for 3 weeks at a time and get paid really well to do it. And I can't. I've got young kids. I'd rather put one of my PJs on, and I just don't want to be gone for 2 weeks at a time or 3 weeks at a time. I mean, I could make what I would make in the emergency department in 2 or 3 months on a 2 week trip and do basically no work, just be available, like not have to see, maybe I'll see one little, twisted ankle or a scraped knee or, but just be available for something that, that's what they want me for. It's just really hard. Maybe when I was in my 30s with no responsibilities, I would have jumped on it. But yeah, I mean, there's physicians that when someone's reaching out and they need something, I've got guys that are willing to do it and they'll go out and do that.
Yeah, no, that's great, and I totally agree. That was for another life or maybe even retirement. That might be a retirement.
Yeah, I could see that as my kids get older and they don't want to talk to me and they've got their own friends and they lock themselves in the room anyway. I could see that in the next 10 years,
Yeah,
just, doing a 2 week trip and just FaceTiming them and saying, all right, well, I know you guys don't want to talk to me anyway, but we're going to talk for a little bit. But yeah, no,
yeah,
I think for retirement, that would be a kind of a great thing to do.
yeah. I'm not para jumping or anything like that, though. I'll be the nurse on the yacht.
Right. You'd be surprised after about a week on a boat, you're ready to get off. Like it's,
No,
trust me,
yeah,
it's not as exciting as you think.
yeah. No, I totally can see that. I've not,
Yeah.
yeah. I've talked to enough people to know the kind of the way that it goes. So it's not always glitz and glam and
Yeah.
super excitement all the time like the movies make it out to be, right?
Nothing like that.
Yeah.
You were there as their help and you will act accordingly.
Yep. Yep.
So
Well, Michael, thank you for your time today. I really
thank you.
appreciate it. Do you have any kind of last minute thoughts before we go?
No, I appreciate it. I enjoy seeing your work on LinkedIn with this kind of hospital security. I wish I could be more involved, but I'm I'm pulled so many different ways. But no, I appreciate you having me on and being able to speak and chat for this hour. And I'm glad you started this podcast. And is this episode 13 already?
Yes, it's episode 13
Wow,
already.
I'm looking at yeah, wow.
That was
That's
kind of my touch to kind of help
yeah,
viewers
no, that's
know what
awesome.
episode we're on. So
Yeah, I looked at it. I was like, didn't you just start this a couple months ago?
yeah.
So you've been grinding. So that's awesome.
Yeah. Well, thank you so much. And I,
Thank
again,
you.
am glad you could be on. I will make sure that your LinkedIn information is in the show notes.
Okay.
So if anybody wants to
Okay.
reach out to you, they can just click right on the link and find you there on LinkedIn.
Awesome. Well, I appreciate it. Excited to see the episode when it comes out.
Yep. Me too. Have a great day.
All righty. Thank you.